Hello, I'm Deborah Sims. I'm a CLL patient from Melbourne in Australia, here at ASH for Lymphoma Australia and the Lymphoma Coalition. And I'm here with one of my former doctors now, Dr. John Gribben from Bart's Hospital in London, who's the president of the European Haematology Association this year. It's a fascinating ASH, a lot of new trials being reported. What have been some of the highlights for you?
Well, I think this year at ASH, lots of new stuff, but a lot of it is not necessarily at the point at which is ready for prime time in use of patients, brand new things, although there are a couple of new drugs we can talk about. But a lot of it, of course, reinforcement of things we already knew. So why is that important? Well, often with these new agents we've had, particularly in CLL, they're published at a time when the follow-up is so short. And every year at ASH, we get the opportunity to see what's happened further on. So that's important for two reasons. We're looking to see, are those curves hanging up the way they are? And the good news is that they are. And secondly, we're looking to see, are there any new toxicities that appear later on when people have been on the drugs for a long time or after they've stopped the drug in other circumstances? And the good news is we've seen is very little evidence of that. We've seen new second-generation drugs, so we've seen more stuff on acalabrutinib, zanubrutinib, now all post-approved, and a whole bunch of newer agents in earlier phase of clinical development, telling us we're going to have lots of choices. Not necessarily anything telling us that any of these drugs are more effective, but certainly the side effect profile looks better. And of course, as we know from our patients, being able to tolerate these drugs well is hugely important. Also, we've seen lots of data on combinations of new drugs together, and that's what we're all looking for. These drugs are very expensive. Being on them lifelong is a huge expense to the community, and of course, a real nuisance for our patients to have to be thinking about continuing to take those drugs every day. I remember talking to you about it before, about taking a drug every day is a reminder that you've got a cancer that you really would be thinking not about. So pretty much all the data is emerging in that setting, looking at stopping the drugs. In the lymphomas, less kind of new breakthroughs the way we've already seen in CLL, and a bit more of kind of incrementally looking to improve on where we are. And of course a lot of stuff on looking at subsets of patients that may respond in a different way. But of course the excitement in the lymphoma field remains the use of the CAR-Ts. And again, what we're seeing here is longer follow-up data showing us that very long plateau looking to be sustained, so that I think we can really say now that CAR-Ts for diffuse large B-cell lymphoma are being offered with curative intent. We're seeing much more on the CAR-Ts in the other subgroups of lymphomas, which we knew would respond, but we haven't got a license to be able to use yet. So follicular lymphoma, CLL itself, where we're expecting to see a license this year, mantle cell lymphoma, really exciting data emerging. So what we're looking for now is how can we make the CAR-T cells safer? How can we make them more accessible? And we're hoping, of course, that by having multiple products out there, we'll be able to have the costs come down somehow. We're looking to see how we can overcome some of the manufacturing issues, and we're looking to see, can we identify subgroups, those subgroups of patients who are not going to do well, to think what do we have to do differently to make CAR-T cells even more effective?
I have to say, for me as a patient, it is such, it's an exciting time to be at ASH and to, as you say, see all these novel therapies that are coming through, to see that CAR-T that is, terrified us a year ago, that they're finding ways around cytokine release syndrome, and even with just the addition of steroids. So I've been quite a few sessions where it's just fantastic.
It's a very fascinating field because, of course, we had for some time thought that we didn't want to come in with preventing the cytokine release. We didn't want to be adding steroids because we thought it would damp the responses. What we're now able to clearly understand is you don't need cytokine release syndrome to be able to have an effective CAR-T. So it's also more experience. So in addition to the steps that we're taking, having more experience in knowing how to handle the side effects and having the confidence to know that we're not dampening down the very response that we previously used to think might be necessary to get those responses has made the whole field be that little bit safer. What's also exciting is the real-world data emerging that's showing that the results in clinical trials can be reproduced in real world, often when the patient population included those who weren't even eligible for the trials. And so often you're thinking, well, you could achieve that if you fulfill those narrow eligibility criteria to get into the studies, but the real world data emerging with quite large numbers now that we've seen here, really demonstrating this can be effective.
How long before you think we'll be at an ASH where we're discussing whether it's going to the role of allogeneic transplant?
Sure. Well, I think in many settings, so diffuse large B-cell lymphoma is one, where patients that I used to take to an allogeneic transplant, I'm now taking to CAR-Ts. So in terms of allogeneic transplants, we'd already say that probably it's pushed it a line back. And where you have access to a CAR-T cell, I would be offering a patient a CAR-T cell rather than an allogeneic transplant. The whole question of whether it replaces autologous transplant is the result is, there's at least 3 ongoing trials that I'm aware of, all comparing doing autologous transplant to CAR-T in the second line setting for diffuse large B-cell lymphoma. None of them reading out here, but 2 of the trials at least have completed enrollment. So I'm hoping at next year's ASH we'll be getting to see some data emerge, asking the question, can we identify at least some sets of patients in whom even an autologous transplant, never mind an allogeneic transplant, might not be the treatment of choice in that setting. The question we've then got for as a society is, how do we afford this very effective therapy that we're going to say we would expand its operation into more diseases earlier in the disease course, where we'd expect it to be more effective, but how can we as societies begin to afford this? The same question, of course, we've had in CLL about the continuous use of agents before.
And in CLL at the moment it's not as effective as it is in the acute leukemias. And is that because CLL, we do have T-cell deficiencies to start with?
I think the new data emerging, in particular when you add in ibrutinib at the time you collect the cells, and particularly when you follow it over. So we saw data from Seattle last year. We're seeing data from Juno this year in their trials, suggesting that this way of overcoming the exhaustion or the fact that these T cells don't work in CLL patients so well, I've absolutely no doubt that's a contributing factor. It's not in patients, but in mouse models. My group presented some data yesterday, clearly demonstrating that we can use these agents to improve the efficacy of CARs in mouse models. So I think it's absolutely clear that healthier T cells can be generated. We're also, of course, talking now about groups of patients in whom potentially who never have been exposed to chemotherapy, and then we'll begin to answer the question how much of the defects of the function are from the FCR treatment rather than just from the CLL itself. I think there's a contribution of both, but it's really heartening to see that maybe I do believe we're entering into an era where chemotherapy is gone in that disease, and we're just praying for the time that it's gone in other diseases too.
Well, I feel in safe hands here. ASH, fantastic news coming out, and we'll be having lots of videos over the next few days. Dr. John Gribben, thank you so much for joining us.
Thank you.